Hi, good afternoon. My name is Mary Jimenez. I'm the Vice President of Strategic Account Management with Caris Life Sciences, and I will be your moderator for today. It gives me great honor to introduce Dr. George Sledge. Dr. Sledge recently joined Caris Life Sciences as Executive Vice President and Chief Medical Officer. He is one of the most influential breast cancer thought leaders in the country. Prior to joining Caris, Dr. Sledge was Professor of Medicine at Stanford University School of Medicine, where he served as a member of the Division of Oncology. He was recently co-director of Stanford's Cancer Institute Cancer Therapeutics Program and served from 2013 to 2020 as Chief of the Division of Oncology. He's trained in internal medicine and medical oncology. Dr. Sledge has devoted his professional career to understanding the biology of cancer and improving the treatment for breast cancer. He is both an active laboratory and clinical researcher with more than 390 scientific publications. Dr. Sledge has countless esteemed positions, including serving as chair of the Eastern Cooperative Oncology Group's Breast Cancer Committee, a member of the Food and Drug Administration's Oncology Drug Advisory Committee, a member of the Department of Defense's Breast Cancer Research Programs Integration Panel, as well as the NCI's Clinical Trials Advisory Board. He's the past president of American Society of Clinical Oncology, and until recently served as both the chief scientific advisor for the Susan G. Komen Foundation and a member of the Triple Negative Breast Cancer Foundation's Scientific Advisory Board. He's received numerous prestigious honors, most notably the Breast Cancer Research Foundation's Jill Rose Award, the Komen Foundation's Brinker Award for Scientific Distinction, the San Antonio Breast Cancer Symposium's William McGuire Award, and the American Society of Clinical Oncology Gianni Bonadonna Award. Please join me in welcoming Dr. George Sledge. Dr. Sledge.
Thank you, Mary. And I'll put up my slides. So if you'll wait just 1 second. While I do that, I'll share the screen. So what I'd like to talk to you about today is an area that's been a huge increase in recent years. And this is the area of genomic profiling in cancer. Let's see. So first, some brief disclosures. I'm the Chief Medical Officer and Executive Vice President of Caris Life Sciences, as you've heard. What I'd like to talk about today is a number of things that I think are important. First, what do we mean by genomic profiling? I'd like to spend a few minutes talking about multi-gene profiling, which has transformed the treatment of breast cancer. I'd like to talk about some recent genomic profiling for individual drug targets. I'd like to talk some about germline mutations and what we've learned from treatment based on that, and then give you some sense of where we're going. So what do I mean by genomic profiling? Well, I have a very simple view of this. If we look at the building blocks of life, and this is DNA and RNA, if we look at either individual genes measured at the DNA or RNA level, or multi-gene measurements used either alone or collectively, this is what we think of when we think of in terms of genomic profiling. Now, recent years have seen just an explosion in terms of markers that we can find in breast cancer and which will affect treatment. This pie chart, which I have my colleagues at Caris generate for me recently, gives you some idea of the breadth of what we're dealing with. First off, and historically, we've thought in terms of breast cancer specific approvals by the Food and Drug Administration. We have drugs for PIK3CA or PI3 kinase. We have drugs now that for which we measure a BRCA1 or BRCA2 inherited mutation. We have amplification events such as HER2 or ERB2. And these have been the standard ones for many years and have basically driven therapy in recent decades. But there's a bunch of others that you probably need to know about. First off, we have what are called tissue agnostic approvals. This is a new class of drugs. There are drugs that are approved by the Food and Drug Administration, basically for all cancer patients who have a particular mutation. Some of these are really, really rare. So for instance, if we look at something like an NTRK fusion gene, we're talking roughly around one patient in 1,000, but some of them are very common. So for instance, if we look at patients who have what's called a high tumor mutational burden, somewhere over 8% of breast cancer patients will have this. And add it all up, these so-called tissue agnostic approvals are probably applicable to about one patient in 10 with advanced breast cancer. And then we have a whole bunch of new targets that are coming along. These are shown on the bottom in green, many of which are already being looked at by researchers in the clinic, many of which I'm sure will lead to FDA approvals in the near future. Collectively, however, what this tells you is that we are now in a genomic era, an era in which what we look at from a genomic standpoint affects the care of a multitude of patients with breast cancer, many with advanced breast cancer, but also many with early stage breast cancer. Now, we've been using genomic assays now for approaching 2 decades. Many of you have heard of genomic assays such as Oncotype DX or MammaPrint or the Breast Cancer Index. These are what we think of as RNA-based assays. We measure RNA in tumor cells or in tumor tissues and use this to come up with a prognostic or predictive assay for patients with cancer. Now, certainly the one that's been used most commonly in the United States has been the so-called Oncotype DX 21 gene recurrence score assay. This is a collection of cancer-related genes along with some reference genes that are used. You take these cancer-related genes that are measurable at the level of RNA. We measure them, we weigh them in an algorithm for what's called a recurrence score. And then that recurrence score allows us to categorize patients with early stage estrogen sensitive breast cancer at being at either low, intermediate, or high risk of distant recurrence of their cancer. And this is now a very old picture dating back to the mid 2000s, showing that patients who have a low recurrence score in general do quite well with long-term follow-up. But the higher your recurrence score, the greater the risk of distant recurrence of the cancer. And so this was one of the early steps that gave us a pretty good idea of who was or was not likely to have a recurrence for early stage estrogen sensitive breast cancer. But what really got doctors excited about this was that this same assay was pretty good at predicting who would benefit and who wouldn't benefit from chemotherapy. Now, bear in mind that if we go back 2 decades ago, the standard of care for all patients with early stage estrogen sensitive breast cancer was that as long as you had a tumor that was a centimeter or more in size, you would get chemotherapy. But what we learned as a result of genomic profiling was that most patients with early stage estrogen sensitive breast cancer simply don't benefit from chemotherapy. But there's a population that clearly does. And if a patient has a high recurrence score, these patients get significant benefit from the addition of chemotherapy as part of their early therapy. Now, this led to the development of large phase 3 trials, such as the TAILORx trial and the RxPonder trial. I had the pleasure to be the chair of the Eastern Cooperative Oncology Group when we developed the TAILORx trial. This trial took patients who had a low recurrence score and assigned them just to get hormonal therapy alone. Patients who had a high recurrence score were assigned to get chemotherapy in addition to hormonal therapy. But we actually looked at a mid-range population, mid-range recurrence scores, and randomly assigned patients either to get chemotherapy plus hormonal therapy or to get hormonal therapy alone. And bear in mind that at the time that this study was conducted, the standard of care was to give all these patients with intermediate recurrence scores chemotherapy. Now, the results from these trials have come out in recent years, presented by Joe Sperano on behalf of ECOG and its collegial cooperative groups. And basically, if we look at patients who have an intermediate recurrence score using one of these genomic assays, one of the exciting things was that was discovered was that for the vast majority of patients, chemotherapy did not add anything add anything to hormonal therapy in terms of preventing distant recurrence of breast cancer. So whereas in the past we would have said, you know, Mrs. Jones, you should get chemotherapy with hormonal therapy because we think there's a small but real benefit. Today, we would say, based on our ability to measure the genes in your cancer, you will not benefit from chemotherapy, and you will get a lot of benefit from hormonal therapy, and therefore let's avoid chemo for you. Major change. If you compare now to 20 years ago, we probably give 80% less chemotherapy than we did 20 years ago for early stage estrogen-sensitive breast cancer. Very exciting. Now, this was extended from the early stage lymph node negative patients to lymph node positive patients with 1 to 3 positive nodes in a trial called RxPonder. Patients in this trial were, if they had a recurrence score of 0 to 25, what we'd think of as low and intermediate risk recurrence scores, and had positive nodes, these patients were randomized to get hormonal therapy alone or to get chemotherapy followed by hormonal therapy. And again, bear in mind that the mantra for decades in the oncology field was that everyone with lymph node positive breast cancer, because of their high risk of recurrence, needed chemotherapy. But we now are pretty confident that this isn't the case. If you look at the results of these trials, and these are survival curves from these trials, looking at the probability of having a recurrence of your breast cancer, what we found is that for all postmenopausal women entered into these trials, there was simply no evidence that chemotherapy added benefit. So again, in the past, this would have been a group that routinely got chemotherapy. Now we tell women with this stage of disease, no, just hormonal therapy alone. Now, the interesting outlier here has been younger women. Premenopausal women do appear to get some benefit from the addition of chemotherapy to hormonal therapy. This is about a 5% difference with long-term follow-up. We're not entirely sure why this is the case. One suspicion that many oncologists have is that younger women may get benefit from chemotherapy because the chemotherapy is a pretty effective way of shutting off the ovaries for many younger women, and that this, in fact, may be chemotherapy as a form of hormonal therapy, though more to come on that in coming years. Now, genomic assays have also suggested that there may be populations of women who don't require any therapy at all. So using a different assay, not the Oncotype assay, but using an assay called MammaPrint, investigators in Europe looked at a fairly large population of women and looked at a group of women who had by genomic characteristics were thought to have very low risk of recurrence or death of their breast cancer. And if we look at this ultra low risk of population, we can actually identify a population of women who, with 8 years or more of follow-up, have a 97% chance. Let me repeat that, a 97% chance of the cancer not recurring outside the breast. Very exciting. And in this trial, a fair number of women actually received no hormonal therapy or chemotherapy. And indeed, these women, if they had this ultra low genetic risk, genomic risk, they did really well. Only about 2 women in 100 with 8 years of follow-up would have a distant recurrence. And so while this was not a randomized trial with regard to the no hormonal therapy arm, there's certainly compelling evidence that there are some women who don't need systemic therapy at all and can avoid the side effects of both hormonal therapy and chemotherapy for their early stage breast cancer. Again, this is very exciting. We all want therapies that will improve outcomes for patients with breast cancer, but at the same time, we want to avoid therapies that add no benefit and only add toxicity or risk. Now, another area where genomic studies have turned out to be very important is looking at other ways by which breast cancers can grow, and in particular, other ways in which estrogen-sensitive breast cancers can grow. And one of these ways is through what's known as crosstalk. Now, if one has an estrogen-sensitive breast cancer, estrogen, female sex hormone, binds to the estrogen receptor inside the cancer cell, and that tells the cancer cell to grow. But we also know that cancer cells have many other growth factors that we can measure, things such as HER1 or HER2, the insulin-like growth factor receptor, and a number of other receptors. And these receptors, in turn, do what's called crosstalk with the estrogen receptor inside the cancer cell. And indeed, if you have some of these other receptors turned on in your breast cancer cell, this crosstalk can lead to cancer cells becoming resistant to standard hormonal therapies. And the pathway, and you don't certainly do not need to memorize this, but the pathway is something called the PI3 kinase AKT-mTOR pathway. Don't memorize this. The important thing to know is that these are things that we can now measure in the clinic, and these are targets for which we have drugs that are active in the clinic and indeed are FDA approved. We currently have FDA approved targets for PI3 kinase and mTOR. There's another one that is going through clinical trials right now for AKT. And we think that these collectively are going to be beneficial in terms of helping overcome resistance to hormonal therapy. And it turns out that knowing whether or not you have a mutation in one of these pathway members is particularly important. So if we look at a trial that looked at one of these drugs called alpelisib, in this trial, if one has a mutation in PIK3CA, that's the gene for something called PI3 kinase, and we compare this to women who don't have the mutation, basically the only women who get benefit from the addition of the new agent to standard hormonal therapy are women who have this particular mutation, shown on the top panel. Women who don't have this mutation don't appear to get any benefit at all, shown on the lower panel. So being able to measure this in the clinic turns out to be really important. This also appears to translate in terms of an overall survival difference as well, if you have the mutation in your cancer. Now, I mentioned that there's other drugs coming along. One of these drugs is a drug called capivasertib, not the most pronounceable of names, but capivasertib, like alpelisib, targets this same pathway. It targets something called AKT, and it appears, at least in the early going, though we need larger data sets, it appears to work only if you have the mutation or a mutation somewhere along the pathway. So again, being able to do genomics and measure mutations matters when we're in the clinic. Knowing the right target matters. Now, there's other targets that are rarer, but which we think are also interesting. You've all heard about HER2 mutations in cancer. Most of the time when we talk about HER2 in cancer, we're talking about what's called an amplification event. There's more copies of HER2 in a cancer cell than there is in a normal cell. But there's also cases where there are what are called somatic mutations in HER2, where the HER2 is sort of locked in the on position and tells the cancer cell to grow. We didn't for a long time measure these. In recent years, we have measured them. They're pretty rare. They only occur in about 2.5% of patients with breast cancer. Interestingly, frequently in patients who don't have the standard HER2 amplification. But if they're there, they may represent a good target for treatment. And indeed, there are a number of HER2 targeting therapies that, at least in the early going, appear to work in this setting. Now, I mentioned that I would talk about germline mutations. Now, I'm sure, as most of you are aware, breast cancer is a disease where the likelihood of developing breast cancer can be passed from one generation to the next. And this could be done as a result of the presence of mutations of the germline, in other words, in terms of your normal DNA. And in particular, these are mutations of what are known as BRCA1 and BRCA2. We can measure this in the clinic. Again, these are part of this panel of genes that we can measure in the clinic. If you have this mutation, it significantly increases your likelihood of developing breast cancer. But if you have one of these mutations, it also makes your cancer a target for drugs that will specifically affect patients who have a BRCA mutation. So 2 of these drugs are already approved by the Food and Drug Administration in the metastatic setting. But more recently, we've looked at one of these drugs, olaparib, for patients with early stage breast cancer who have a BRCA mutation. And in a trial called the Olympia trial, patients were randomly assigned either to receive chemotherapy and surgery, or surgery followed by chemotherapy, along with radiation therapy. And then some of the patients received and some of the patients did not receive olaparib. Now, the results of this trial, and let me go forward, are shown here. This was actually presented at San Antonio a couple of years ago. And the results of this trial are a striking vindication of using drugs that target a particular pathway that we can measure in the clinic via genomic analysis. And what you can see here is that we can significantly lower the likelihood of a woman with one of these BRCA1 or BRCA2 mutations of having a recurrence of her breast cancer if we give her a drug known as a PARP inhibitor, in this case, a drug called olaparib. So again, this is a case where genomics has changed how we look at the disease and how we treat the disease. And this in turn has led to a reduction in the likelihood of having a distant recurrence of the breast cancer. While the survival data for this trial are as of yet immature, I think we're all pretty confident that this significant improvement in terms of distant disease-free survival will ultimately lead to a lowering of the death rates for patients who have a BRCA mutation. And here you see the survival data. Again, it's fairly immature, though there's an emerging evidence of improvement in overall survival. Now, I mentioned earlier what we call tissue agnostic approvals. There are now 7 FDA-approved indications, 6 different drugs for so-called tissue agnostic approvals. And again, these are the case where if you have the genomic lesion, if we can measure something in your cancer, we have a drug that will work across human cancers, not just breast cancer, will work for colon cancer, lung cancer, thyroid cancer, you name it. We didn't used to measure these things. We didn't used to measure these things in some cases because we didn't have very good ways of measuring them, but in some cases because they were so rare, we never even thought about them. I mentioned earlier the NTRK fusion gene, which is based literally 1 or 2 patients in 1,000. RET fusion gene, again, 1 or 2 patients in 1,000. Some of these are very, very rare, but if you have the mutation, it makes a world of difference. And we can now measure this using genomic assays. And this has led to these tissue agnostic approvals where regardless of whether or not you got breast cancer or some other cancer, if you have the genomic lesion, we can treat you. And again, if you look in breast cancer, these are pretty common. In estrogen receptor positive breast cancer shown in this slide, we see a fair number of patients who have a high tumor mutational burden or have what's called mismatched DNA repair lesion. And again, these rare mutations that I mentioned to you. Overall, in ER positive advanced breast cancer, this is somewhere around 6% of patients. If we look at triple negative breast cancer patients, the number is higher. It's a little bit over 10% of patients will have one of these genetic lesions shown on top in the blue, where one can think in terms of receiving a drug for a tissue agnostic approval. These are going to only get more common in coming years because there are a lot of new drugs being tested that we suspect will be beneficial across a lot of different patient populations. So watch this space because my guess it will fill up over time as a result of the increase in the new targets shown down at the bottom of the slide. So what are we going to use these genomic-based approaches for? I'm very excited, and indeed one of the reasons I moved from my position at Stanford to Caris was because of this. I'm very excited over our prospects over the next 5 or 10 years. I suspect that when a woman comes in to have her mammogram sometime in the next 5 or 10 years, at the time she has her mammogram, we'll probably be able to test in her blood as to whether or not she has evidence of cancer DNA in her blood. If a woman has had surgery and chemotherapy or hormonal therapy for an early stage breast cancer, we already have pretty compelling evidence that we can detect women who are at high risk for developing a recurrence of their breast cancer in a reasonably short period of time through genomic testing. As many of you are aware, particularly in estrogen receptor positive breast cancer, less so in triple negative or HER2 positive breast cancer, many of the recurrences we deal with are late recurrences occurring 5 or 10 or 15 years out. So doing surveillance for these late recurrence, hopefully finding them before it turns into an obvious distant metastasis or spread, might allow us to intervene at an earlier point in time. And then finally, for patients who have metastatic disease, we already do regular genomic testing. We can do that off of a solid tumor, or we can do it through what's called a liquid biopsy, where we draw some blood and look for cancer DNA or RNA in the blood. And we're going to see more and more of this over time as we get better and better at this and understand more and more. Let me give you an example of what I think of in terms of surveillance. This is from actually one of my Caris colleagues, Milan Radovich, who did this study along with Brian Schneider at Indiana University when he was still there. If you look at a patient who has a triple negative breast cancer and gets preoperative therapy, and then goes to surgery and has radiation therapy, and then you draw some blood on that patient subsequent to the surgery, sometimes you can measure what we call circulating tumor DNA in their blood, cancer DNA that is spilled into the blood. Sometimes you can't. If you can measure it, boy, that's a huge difference. Patients who are ctDNA positive are at much, much higher risk for having a distant recurrence of their cancer. Now, I'm a great believer that finding bad news early doesn't turn it into good news just by itself. But if we can determine which patients are at the greatest risk for having a distant recurrence fairly early on, maybe we can intervene early on and prevent distant recurrence and death. This is something that many investigators in the cancer field are looking at now. So with that, I'm going to come to an end of my talk. I'm going to turn things back over to Mary Jimenez, who I suspect will have some questions for me, but a pleasure speaking with you.
Yes, thank you, Dr. Sledge. It's exciting to see the promise where we're going with breast cancer, and we're getting smarter and smarter each day and looking at these markers to make better informed decisions for patients. So a couple of questions, I think, as we look at all these markers in cancer, when should a patient get profiled right now?
So it's a great question. So currently, the current FDA indication for genomic profiling is an indication basically for all patients with metastatic cancer. Now, this obviously by definition includes patients with metastatic estrogen sensitive, triple negative, and HER2 positive breast cancer as potential candidates. The question is always, what do you do with the information that you get? And there are times and places for patients with advanced breast cancer where genomic profiling is incredibly valuable, incredibly important. I mentioned, for instance, if someone has metastatic HER2 positive breast cancer, we have drugs that have very specific requirements in terms of who should receive those drugs. Drugs like alpelisib for PIK3CA mutant breast cancers. That we measure doing a genomic analysis either on the primary tumor or it can be done on a liquid biopsy. We have cases such as in triple negative breast cancer, commonly where if a patient's tumor has what we call a high tumor mutational burden or has something called DNA mismatch repair, again, things we can measure via genomics. Those are things that give one a real leg up in terms of exciting novel therapies, in particular immunotherapies for their breast cancer. But as a general rule of thumb, if a patient has an advanced cancer, a metastatic cancer that's spread to the lung or liver or bones, it's always reasonable to consider doing genomic profiling. Now, an unanswered question, and this is one that we'll answer in the next few years, is how often do we do this profiling? Because we know that cancers change in response to therapy. Cancers undergo mutations that make them resistant to therapies. One of the things that we're trying to learn right now is, should we be doing testing just once? Should we be doing it repetitively over time? And how should we treat patients based upon those sorts of testing? The honest answer is we don't know yet. But again, I think part of physicians' excitement about genomic profiling is that we can see a way forward to responding in real time to the changes in breast cancer that doom patients to die of their disease if they have advanced disease. Now, the other areas that I mentioned, around the time of diagnosis, the post-surgery surveillance areas, or the late looks for early metastatic disease, are all areas that are under active evaluation by large cooperative groups, by national authorities, and by a large number of molecular diagnostic companies. We'll learn a whole lot more about that within the next 5 years. And indeed, some of these studies will be available within 2 to 3 years.
Okay, wonderful. Thank you. You also provided, Dr. Sledge, a lot of great information, on different markers and looking at different pathways in the field of breast cancer and what's least expressed versus highly expressed. And, you gave some examples in, the lower, maybe a population that's least likely to have this expression. Not knowing still, and as we're growing and looking at this diagnostic world of profiling, could you share with us, kind of what a report would look like and maybe what's most critical on a report? I think it would be helpful, since this is ever changing, and, kind of what does Caris's report look like, right, for patients if they were to get profiled,
Sure. Can I show one from Caris?
Sure, that would be super helpful.
Okay, let me.
I think as Dr. Sledge is pulling that up, it's really helpful, I think, for us to kind of see what that report looks like, right? As patients go in, they kind of would know, and of course, these physicians and nurses go over these reports with them, but thought it would be helpful for the group today to be able to see what a report would look like. And it's like a blueprint. It's a roadmap, right? And so there's a lot of information, but I think it's sequenced in a way that can help patients in stair-stepping, like what's most important versus what you can save for later. So I'll let Dr. Sledge kind of go in and kind of explain those reports.
You're allowed to call me George. Everyone else does.
Dr. George. Curious, right. George. Okay.
Indeed. I've been called that as well. So can you see this on your screen? Yes. Okay. So, I work for Caris, but I will also say that we're one of multiple molecular diagnostic companies, and many of which do pretty much the same thing, and therefore will have similar reports. So basically, what happens is your physician orders one of these tests. The pathologist will then take a piece of the tumor sample, or alternatively a liquid biopsy with a blood sample, and this will be sent off to a molecular diagnostics company such as Caris. And then over a period of 10 days to 2 weeks, that will undergo genomic profiling at one of those companies, and then the results of that profiling will be sent back to your institution and to your physician. And the sort of test reports that you'll get from our company are shown here. For instance, we look routinely at standard things such as estrogen receptor, progesterone receptor, and we can use those to suggest whether or not there's benefit for a particular therapy. In our case, we helpfully label green for benefit and red for lack of benefit. But then we look at cancer-specific biomarkers, and these are things such as we show on the bottom, where we show ERB2 or HER2 being amplified. Again, something that is a predictor of benefit for patients with cancer. We'll also frequently look at a number of other mutations that could be present in the cancer that could be valuable because they're ones, again, that we frequently know as a result of the tissue agnostic mutations that they'd be valuable. So your physician will get a report, something like this. This is another page, basically, from the same report. Again, green is a go, red is a stop. It's very important to know what not to treat with. It's very important to know what biomarkers are relevant for particular cancer types, breast cancer and other cancers. When we send out these reports, we're very careful. We're very careful because these are based upon Food and Drug Administration approvals. And those Food and Drug Administration approvals, of course, are the law of the land. We do not want to suggest or promise a therapy to a patient that is outside the current levels of evidence. So we look very closely at the levels of evidence, and these are what we think of as level 1, level 2, or level 3 level of evidence. But what we as a company do, because we think this is very important, because cancer is changing ever so rapidly, and because we are frequently finding mutations in a patient's cancer for which there's not a current FDA-approved therapy, Caris has a what's called a right in time process, where we actually will match up patients with clinical trials that are with agents or drugs that are specific to a patient's particular mutation. And we think that this is part of our responsibility to the larger community. We don't just want to tell patients about what's been available. We want to talk to patients about what might be available in the future and how they might be able to contribute both to the future of cancer medicine and to their own care.
Wow, thank you so much for I think that's super helpful for patients to be able to see that. Can you speak to the type of support Caris provides in addition to molecular testing? Like, what else does Caris have in place, like in regards to like medical science liaisons?
Sure.
I know that doesn't play to the patient directly, but often it can indirectly to the physicians to kind of guide them, like if a mutation comes back, right? So, I mean, a mutation, now you mentioned earlier in those clinical trials, how does a patient know, like, say, for instance, a new drug is approved now and they carry this rare mutation and there's now a drug approved? How does Caris notify those patients? Or how does the practice get notified to notify the patients? That's really the correct way. We would always go through the provider. So how is Caris making sure?
Yes, and by the way, I don't want to pretend that Caris is the only company doing this, since I have a fairly obvious conflict of interest. But I'll brag about Caris.
Other companies, yeah.
Okay. Fair. Which is to say, usually when you order a laboratory test, when you go into a hospital or a doctor's office and you order a laboratory test, all that you get back is the result. Your calcium level is high, your hemoglobin is low. You get that result back, but your doctor isn't given any additional information other than that it's high or low. We believe strongly that the molecular diagnostics field is something different in that we have different requirements because we're dealing with very serious diseases and we're dealing with rapidly evolving, rapidly changing landscape. So if, for instance, there wasn't a drug available last year when you were tested, but there is one now, we actually reach out to physicians' offices and update them on that. Doctors are great at keeping up with the medical literature, but the medical literature is changing so rapidly that sometimes it takes a few months to catch up. So if we know that there's a new agent that might be applicable to a patient's case, then we do catch up. Now, in addition, we have a large group of what we call molecular science liaisons. And these molecular science liaisons actually go out and speak to individual oncologists, bringing them up to date from a knowledge standpoint in terms of what's going on. Much of what is done today is also done in hospitals and in what are known as molecular tumor boards. And our folks go out and help staff these molecular tumor boards, giving up-to-date information in terms of genomic analysis. So I think these are some of the ways in which we can help folks out. I already mentioned that we also will be helpful to patients in terms of being able to pick out clinical trials that they might be candidates for based upon the genomic analysis of their tumor. So in these many ways, I think molecular diagnostics companies such as Caris can help out patients.
Wonderful. Well, thank you so much. We appreciate you sharing your wisdom and insight in the field of breast cancer. Once again, the Alamo Breast Cancer Foundation is thrilled to have you speak on behalf of the field of diagnostics and companies represented in the diagnostic field, like Caris Life Sciences in particular today. You shared some information relevant to Caris, but as you mentioned, there are many companies out there that offer great tools and resources. And the important thing is to be informed and ask your provider. So thank you so much. And I think we have concluded our program.
If I could make one last shout out.
Sure.
First off, thank you for facilitating this, but also thanks to the Alamo Breast Cancer Foundation, which is a wonderful organization that I've worked with over the years and have huge respect for its great ability to educate breast cancer patients about their disease.
Agreed, Dr. Sledge. Thank you so much.
Thank you.